Hi, I'm Raymar B. Callado from Section Weidenbach. For this video, I will perform nasogastric tube feeding or NGT. But first, what is nasogastric tube feeding or NGT? Nasogastric tube feeding is the installation of specially prepared nutrients into the stomach through a nasogastric tube. For the assessment, assess client's need for enteral tube feedings, impaired swallowing, decreased level of consciousness, head and neck surgery, facial trauma, surgeries of upper alimentary canal. Identify clients who need tube feedings before they become nutritionally depleted. Auscultate for bowel sounds before feeding. Absent bowel sounds may indicate decreased ability of gastrointestinal tract to digest or absorb nutrients. Obtain baseline weight and laboratory values. Assess client for fluid volume excess or deficit, electrolyte abnormalities, and metabolic abnormalities such as hyperglycemia. Enteral feeding is to restore or maintain clients' nutritional status, provides objective data to measure effectiveness of feeding. Verify physician's order for formula, rate, route, and frequency. Laboratory data and bedside assessments such as finger stick blood glucose measurement are also ordered by the physician. Tube feedings, laboratory tests, and bedside tests must be ordered by the physician. For the objectives, first to provide alternate means of ingesting nutrients for patients with functional gastrointestinal tract. Second, to intervene in pre-existing or impending nutritional depletion from debilitation. Third, to provide aggressive management for certain disease condition and anorexia. Fourth, to provide means of nutrition if there is an inability to swallow or an existing obstruction in upper alimentary canal. Fifth, to provide nutrients for patient in comatose or semi-conscious state. Sixth, to provide increased nutrients requirements above oral consumption. 7. To provide nutrients for postoperative patients with bowel sounds presence. 8. To maintain fluid and electrolyte balance. The equipment used for this procedure are disposable feeding bag and tubing or ready-to-hang system, 20 to 50 ml syringe, stethoscope, pH indicator tip, prescribed enteral feeding formula, gloves, equipment to obtain blood glucose by finger stick, kidney basin, water to follow feeding in a measuring or calibrated glass, measuring container from which to pour the feeding if the syringe method is used, and tissue. Step 1. Explain the procedure. Discussion and explanation help allay anxiety, encourage patient cooperation, and prepare the patient for what to expect. Step 2. Perform hand hygiene. Hand hygiene deters the spread of microorganisms. Step 3. Prepare feeding container to administer formula. Have tube feeding at room temperature. Cold formula may cause gastric cramping and discomfort because the liquid is not warmed by mouth and esophagus. Shake formula container well and fill container and tubing with formula. Filling the tubing with formula prevents excess air from entering GI tract. Step 4. Place client in high Fowler's position or elevate head of bed 30 degrees. Elevated head helps prevent aspiration. Step 5. Determine tube placement. Aspirate gastric contents to check for gastric residual. Return aspirated contents to stomach unless the volume exceeds 150 ml. Presence of gastric secretion indicates that the distal end of the tube is in the stomach. Residual volume indicates if gastric emptying is delayed. Delayed gastric emptying may be reflected by 150 ml or more remaining in the client's stomach. Measure pH of aspirated GI contents. fasting gastric pH is usually equal to or less than 4. It is only infrequently greater than 6. In contrast, intestinal aspirates usually have a pH equal to or greater than 7. Observe the aspirate's appearance. Gastric fluid is usually cloudy and grassy green or tan or off-white in color. In contrast, intestinal fluid is usually deep golden yellow and is clearer than gastric contents. Consider the results from pH testing and the aspirate's appearance together. An aspirates with a low pH and a typical gastric fluid color indicates a high probability of gastric placement. In contrast, a golden colored aspirate with a high pH indicates a high probability of intestinal placement. Step 6. Initiate feeding. Pinch proximal end of the feeding tube prevents air from entering client's stomach. Remove plunger from syringe and attach barrel of syringe to end of tube. Fill syringe with measured amount of formula, release tube, and hold syringe high enough to allow it to empty gradually by gravity refill. Repeat until prescribed amount has been delivered to the client. Gradual emptying of the tube feeding by gravity from syringe or feeding bag reduces risk of abdominal discomfort, vomiting, or diarrhea induced by bolus or too rapid infusion of tube feeding. Step 7. Advanced tubing feeding gradually. Tube feeding should be advanced gradually to prevent diarrhea and gastric intolerance to formula. Step 8. When tube feedings are not being administered, cup or clamp the proximal end of the feeding tube. Prevents air from entering stomach between feedings. Step 9. Administer water via feeding tube as ordered with diluted formula. Provides client with source of water to help maintain fluid and electrolyte balance. Step 10. Rinse bag and tubing with warm water whenever feedings are interrupted. Rinsing bag and tubing with warm water clears old tubing feeding and reduces bacterial growth. Step 11. Measure amount of aspirate residual every 4 hours. Evaluates tolerance of tube feeding. Step 12. Monitor finger stick blood glucose every 6 hours until maximum administration rate is reached and maintained for 24 hours. Alert nurse to client's tolerance of glucose. Step 13. Monitor intake and output every 24 hours. Intake and output are indications of fluid balance or fluid volume excess or deficit. Step 14. Weigh client daily until maximum administration rate is reached and maintained for 24 hours. Then weigh the client 3 times per week. Weight gain is indicator of improvement nutritional status. However, sudden gain of more than 2 pounds in 24 hours usually indicates fluid retention. Step 15. Observe the return of normal laboratory values. Improving laboratory values, for example, albumin, transferrin, and pre-albumin indicate an improved nutritional status. For the evaluation, first, patient tolerates feeding well and weight is maintained or increased. Second, appropriate residual is obtained from aspiration of stomach content. Third, patient complies with feeding procedure. Fourth, intake and output balance is maintained. Fifth, nasogastric tube functions efficiently and remains patent. For the documentation, record the amount and type of feeding, client's response of tube feeding, patency of tube, and any side effects. Report the client's tolerance and adverse effects.